Good morning. First, I'd like to say thank you to Julio for allowing me to come here today. Originally, the speaker was Dr. Koufax. Dr. Grant Koufax, left San Francisco to take a job in the East Coast in this house painted white. So I am filling in for San Francisco in the perspective from the policy perspective. The other thing I think it's important is that Diane will speak to you later this week regarding the science behind the policy of beginning treatment early, as well as I want to give you an understanding that this is San Francisco. While we've been talking about developing nations, there's a lot of work that we need to do in developed nations around beginning the use of treatment as prevention and treatment as treatment. So I don't want to say that I'm here to present something about an urban American experience. Everyone has seen this slide, Dr. Das, and we presented it in many conferences, again, around the comprehensive approach to HIV that we are taking in San Francisco, from primary prevention, addressing substance use, to the treatment cascade. I also wanted to I modified this slide slightly to let you know that we also see HIV surveillance as a programmatic tool that we are using within this context. So again, a very big comprehensive approach to HIV, but today I'm focusing on treatment. Many of you have seen this information around San Francisco. We have a long history of addressing this epidemic. We are primarily a MSM epidemic, with 87% of our cases amongst gay men and MSM. I think another thing that's important as we do these talks across the country is a lot of times people call San Francisco the Cadillac, if you will, of services. But I was at a meeting where someone said, no, they're not just the Cadillac of service, you are the Cadillac of clients. And that's a huge misconception. San Francisco serves some of the most marginalized populations in our jurisdiction, most of them dual diagnosed, triply diagnosed, with syndemics, both impacting not only their HIV, but their other co-conditions. And we wanted to clarify that for you. Oh. The other thing that is really important for you to understand, that before we made any of these shifts, San Francisco is not at an epidemic. We are endemic. Even with all the work that we have done in order to prevent HIV and take care of those living with HIV, we are in an endemic state. That means if we continue to do the same thing over and over, we can keep this epidemic going on forever in San Francisco. So we are constantly monitoring our data to look to see what else must occur in order to reduce this epidemic and end this epidemic in San Francisco. I'd like to either introduce you or reintroduce you to the San Francisco Department of Public Health, because I also understand that people probably are not clear as to what this means. San Francisco is a city, but it is also a county, and that is very important in the state of California. Counties run health systems. Counties have a significant contribution to the safety net health system for the lowest income clients and residents of the jurisdiction. County is what also give us the opportunity to run the Ryan White program, because you need to be the largest elected appointed official is provided the resources in order to administer that. Counties are also required to have health officers. Health officers make local decisions to make sure that the county and all abide by the law, but also allows us and gives us the authority to look at our local epidemiology and make health decisions and standards for that county. And that's really important. So if you look, the other thing that's important here is if you look in San Francisco, typically the box In blue is what you call public health strategies or public health. We call it population health and prevention. The other side in orange is what people call the health delivery system. And the great thing about San Francisco is that we are one health department overseeing both. Let me go a little deeper. The box in blue is called population health and prevention. That does your traditional public health from emergency response to communicable diseases, to public environmental health. On the other side, what you see is our safety net program. That is a robust system of us operating the hospitals, not only having 15 clinics that we have, off-site clinics in our San Francisco General Campus. We also have a robust partnership with UCSF. So for many years, for about 30 years, we have been serving people living with HIV and seeing their actual health progress over those 30 years. So no disrespect to our colleagues, we are huge also in research, but we have a huge cohort, if you will, of people living with HIV that we must take care of every day. The other thing that you should know about San Francisco is that we're huge on HIV research. Not just do we have an HIV research section, but our HIV epidemiology section does multiple research around the world and in San Francisco. Our HIV prevention section does research. Our STD prevention does research for HIV. Our partnership with UCSF, our partnership with CAPS, and even research in our jails, working to make sure. So we are constantly looking for new evidence to make public health decisions. However, the fortunate is that as we are looking at our own data to help publish, because we are big about publish, we also use that data and those results real time to make policy recommendations as we do locally for San Francisco. As you can see, we looking at the CASCADE, comparing both the US to where we are in San Francisco. For us, we know we must do better. We are doing better than the rest of the US, and this lets us know that we have an obligation to make sure that what we're doing works for the people and optimizing the health of those living with HIV. Our goal here as we go forward developing our policy around care is looking at this from a continuous quality improvement and utilizing these metrics to measure where we are. A lot of times we have heard a lot of feedback about our new guidelines, about when to begin. What we began to do is also look at where are we in San Francisco as compared to the US. If you look at even before the guidelines were released from HHS in March, our average is below 500. Our median CD4 at first time medical visit is below 500. And for people of color, it is at or below 350. So the idea that San Francisco is saying everyone should be on treatment, those who are identified should already be on treatment. So our goal is to do treatment as prevention for those living with HIV first. The recommendations were released in 2010. The guidelines based on the benefit of antiviral therapy. Again, this was done in consultation with a group of our colleagues, Diane Havelier working with, at the time, Dr. Katz, Dr. Mitch Katz, who was not only Director of Public Health, but the health officer, remembering that the health officer's role is to look at local epidemiology and create standards for health. It was discussed in a community forum, and again, Diane will give you a little bit more information at how the release of these guidelines increase people's uptake of ART. The primary intent, again, was to help the benefit of the individual living with HIV. That was the goal, the primary goal. Secondary, we were hoping, waiting for the data. There was definitely some cohort data and some information on modeling, but the idea was that this was about the patient, the direct benefit to the patient. Again, we have a vision in San Francisco for eradicating HIV. We're keeping to that vision because if we stay calm and say, oh, we're only going to be here until there is a vaccine, or we're going to wait until, we have to keep our vision motivated. And so when we look at this, we know this is where we want to be and this is where we are. And we're putting the efforts together to make this happen. Unlike other places, we have strong stakeholder and community involvement in this effort. We have excellent data. We know our epidemic. We are relatively well-resourced. We have a good access to care and treatment, and we have research driving our decisions. And most important, we have strong political support. But the data are also in around treatment as a benefit for prevention. So what does this mean for us? It's just that this is a win-win. Again, because we started our guidelines to take care and optimize the health outcomes of people living with HIV, and yet the data has shown us that they can also reduce transmission. But there are some policy things that we must address. So 3 things I have chosen, given the limitation of time, is balancing resources, maximizing the use of data for the continuum of care, and monitoring and evaluation. People think that in San Francisco, we don't have to make this tough discussion about resource. Resource needs to be redirected to interventions that have demonstrated effectiveness. We have had, I could tell you as the policy director, not only in treatment, but in our entire cascade, moving resources from one place to the other, where a community is entrenched to doing a specific intervention, has not been easy. But we had to make tough choices in order to make sure that we can fulfill the cascade for prevention. But treatment as prevention is also important for you guys to understand that it's also about reducing health-related disparities, reducing stigma, and increasing health and wellness. Our Director of Public Health is also understanding that if we want to increase access to resources for people living with HIV, we must also reduce ER visits and hospitalization. We have to reduce missed clinic visits. We have to reduce morbidities, inflammation, opportunistic infections. There's no reason why someone should be coming into San Francisco with MAC in the ER in 2012. We have to reduce all of those costs in order to increase health outcomes and therefore redistribute those dollars to our prevention care and treatment effort. We also need to let you know we have blessed with multiple funding from multiple sources. However, it is not the investment in testing, engagement, retention, and treatment adherence that we see is one of our biggest challenge, is the siloing of these databases that all are in. And what occurs is that we are spending so much time trying to navigate a person through care with data not speaking to each other. And therefore, what we're embarking on is working locally and at the federal level to begin to change the policy of the sharing of that information for the benefit of the patient. I believe patients are not lost to care. Care is lost to patient. We know in public health the data of where you live. It is the political will to allow us to use that data to re-engage you in care. That is something really different in the United States. For a lot of reasons, we built firewalls for protection, and those protections were based around concept of the 80s and the 90s, and they are still around. And this is huge because when it comes to resource, we are using so much resource in siloing these databases that what we know is fragmented data gives us fragmented health outcomes. And so this is something that all in the United States and developing countries, but as well as if you're doing, could you imagine doing an RCT with 63 databases, not speaking to each other? Impossible. But that is how it happens on the ground. And if you want to maximize efficiencies and put more dollars in other places, you're going to have to maximize the resource of your data. The last one is we're going to be so important to measure these outcomes, to really pay attention not only at the individual level, but at the population level. But with grant resource usually comes 8 million variables, or what I call widgets. Measure this, measure that, measure this, measure that. Every variable is different. Again, the reasons why everybody has 800 different databases is because every grant funder wants their own database capturing different information. We want to go to some very simple, what we call hard metrics. And we are presenting these metrics. We have been advocating for these metrics in order to make sure that these are metrics that are sustainable at the individual level with clinicians, as well as us in public health at the population level. And we need to understand that we will always need to be constantly re-looking at our data to make sure we have to change course, that we can do this quickly. We use this a lot in San Francisco. It's what we call ourselves in the exercise we're going, this is not a fantasy exercise. This is not, we had to have bold and candid conversations at all levels in order to make this happen. People think that we're San Francisco, therefore it just happens. No. Jurisdictions are going to have to make really tough choices. This is not about paying for the same intervention that you've been doing over and over again. This is not just about holding on to what you have done that you like to do in the 1980s and keeping that intervention going. We also know that we have to do a lot of work with the system. And when I mean the system, it's not just the ASOs, but it's the medical care systems. It's our doctors. We need what we call a Debbie for docs. An intervention, you guys should do, researchers, how are you going to get docs who have waited and have embedded in themselves to old school regimens and old school policies that even when we come forward sharing with them new information, stay and refuse to move? How do you take doctors where we have evidence to show that substance users can engage in care and are willing to engage in care, but it's the doctor who is refusing to begin that therapy? Those are the type of interventions that we need to address going forward to make this happen. I leave you with a quote from Maya Angelou. It's one of my favorite quotes. Do the best you can until you know better. Then when you know better, do better. Thank you.